Did that go through?
Yeah, and so it'll save on mine and I'll share it with you all
Okay.
after. Okay, so Dr. Evans.
Over to me,
Let me see, I can pass it to you. Okay, excellent.
Well, thank you very much for the invitation to speak to your lung cancer disease site group. Dr. Ung and I were just reminiscing before we started. It's been a little over 20 years, I guess, since I did some lung cancer clinics with Dr. Ung and others there at Sunnybrook. And so it's nice to see you virtually and to present today on the impact of smoking on lung cancer outcomes. So I'm trying to advance. There we go. Oh, advanced too far. So we're going to have to figure out how to do this gently, I guess, is the answer. So the cigarette's the delivery vehicle for nicotine, but in combusting tobacco, there are estimated to be like 7,000 constituents in cigarette smoke, a lot of them known to be harmful, almost 70 carcinogens. You see some of them listed there. And so we all know that smoking can lead to lung cancer, head and neck cancer, and a variety of other cancers, probably a dozen other cancers. Perhaps what was less well known until 2014 in the Surgeon General's report is that if you continue to smoke when you have a diagnosis of cancer, there is now sufficient evidence to indicate that it increases all-cause mortality, which is perhaps not surprising because people might get heart attacks or strokes or have respiratory failure from chronic obstructive airways disease, and certainly could get second primary cancers. But I think what was a bit surprising from the Surgeon General's report was the increase in cancer-specific mortality. As well, there was an association, not as strong, but nonetheless an association between smoking after a diagnosis of cancer with increased risk of recurrence, a poorer response to treatment, and increased treatment-related toxicity. And this just shows you sort of the magnitude of the estimates from that report. And if you look at, say, overall mortality, there were 159 studies. There were 87 associations, negative associations, and 62% were statistically significant. And so you see the magnitude of risk. And so a 50% increase in mortality if you're a current smoker, or a 22% increase if you were a former smoker. And you see that for cancer-related mortality, a significant increase in current smokers, and a substantial number of studies that are statistically significant. So one of the conclusions from that report was that you should quit smoking at the time of a cancer diagnosis, and it might reduce the risk of dying by 30 to 40%, which is a pretty remarkable increase in survival. And it's led many people to suggest that maybe cigarette smoking, tobacco use should be considered the fourth cancer treatment. Now, how can that happen? Sorry, I go too quickly there. To the previous. There we go. Oh boy. I have a sensitive mouse here. Well, tobacco, or nicotine in particular, works through an N-acetylcholine receptor, specific one. And as you can see, it stimulates a number of the signaling pathways that oncologists are quite familiar with. So you see the RAS, RAF, MEK pathway causing cell proliferation. You see pathways that lead to angiogenesis or apoptosis or motility and invasion. And so nicotine could drive these pathways, hence changing the phenotype of the cancer, leading to a worse outcome. And this is a slide I got from Graham Warren, one of the leaders in smoking cessation and cancer, just showing the complexity of nicotine driving various signaling pathways in cells that could lead to changes in the phenotype of the cancer. So in 2022, I was the editor for a special issue of Current Oncology on smoking after a cancer diagnosis. And there are 13 articles in that, and I would encourage those of you listening to have a look at that special issue. One of the articles by Dr. Christian Finley, who's a thoracic surgeon in Hamilton, was on the negative impact of cigarette smoking on cancer surgery. And he covered all different types of cancer surgery, including thoracic surgery. And there's a common theme. That is that those who continue to smoke up to the time of their operation have more returns to the operating room and an increase in 30-day mortality. And they also are more likely to have postoperative complications from their general anesthesia or pulmonary infections. And of course, there can be impacts on the surgical wound itself with delay in healing, leading to wound dehiscence in some situations, or hernias in later circumstances, and more risk of infections. Now, as it relates to radiation therapy, we know the radiation therapy works best when the blood oxygen levels are normal. When you smoke, that lowers the oxygen tensions in the tissue and can reduce the rate of complete response and decrease overall survival and progression-free survival. I have on this slide an example from head and neck cancer, just to show how dramatic can be, where smokers had a 45% complete response rate versus 74% complete response rate in the non-smokers, and a remarkable difference in 2-year survival of smokers versus non-smokers. So in that same issue of current oncology, Jacek Jasem from Poland and a colleague described the outcomes of radiotherapy in cancer and included a section on lung cancer. The studies they included had to have individuals who were identified as both active smokers receiving radiotherapy or combined modality therapy, as well as there being a control group in this study. And they had to have at least one specific endpoint, such as an overall survival or progression-free survival, etc. So there are 14 studies in non-small cell lung cancer, different types of radiotherapy or combined modality therapy, and 4 studies in small cell lung cancer. And this shows you the results of a number of these studies. This is all non-small cell lung cancer shown here, higher risk of local regional recurrence in smokers versus non-smokers, greater risk of pulmonary toxicity in this particular study, quite a significant difference. But in a study with hypofractionation, there was actually said to be a lower rate of pulmonary toxicity in those who were active smokers. But you can see that the numbers are relatively small of current smokers in that particular trial. Here we have 3 studies from Jasem's study of SBRT. And here we have fairly consistent results that the hazard ratio for death in smokers versus never smokers shows a 30% difference in survival for the individuals who smoke versus those who don't, and greater toxicity. This study showed, Roche showed 2-year overall survival in quitters compared to continued smoking of 78 versus 69%, and distant failure rates was higher in both those who were current smokers and former smokers versus never smokers. In terms of combined modality therapy, the results are a little bit mixed. There's a study that shows no difference in 1-year survival, but a second study that shows a worse 2-year survival in smokers, 41% at 2 years versus 56%, which was statistically significant. As well, a higher risk of local recurrence, higher risk of radiation pneumonitis and infections, and of course, a higher risk of second primary cancers. The same applies in the small number of small cell lung cancer studies. Vedic from London, Ontario, showed that the median overall survival in former smokers versus continuing smokers was much higher, 18 versus 13.6 months. Similarly, the Johnson study showed the difference between those who quit versus those who were continued smokers. And you can see that there's quite a remarkable difference from those who are continuing to smoke at 47 weeks versus those who were never smokers at 70 weeks. And second primaries were higher, as one might expect, in 2 studies. Recently, in the Journal of Thoracic Oncology, Keeney and all did a systematic review and meta-analysis of quitting at or around diagnosis. And they used from the data from the trials they reviewed, a summary relative risk. And there were 21 articles, 10 of them in non-small cell, 5 in small cell, and 6 that had both cell types included or were said to be unspecified types of non-small cell lung cancer. There's a lot of variability in the study designs and patient characteristics, but nonetheless, a consistent benefit of smoking cessation at or after a diagnosis across all the cell types. And you see this relative risk in all cases is a significant improvement over continued smoking. And so quitting significantly is associated with improved survival for all cell types. And their summary relative risk was 0.71, which translates to a 29% improvement in overall survival of patients quit at or around the diagnosis compared with continued smoking. For those who like visuals, here's the forest plots in non-small cell lung cancer, showing that most of the studies demonstrate favorable benefit of quitting at the time of diagnosis. And one exception here is adenocarcinoma. The other that's sitting on the line is stage 4. This shows it for small cell lung cancer, where it's quite clear that there's a benefit of quitting at the time of diagnosis. And here's for the group of patients of all cell types or both cell types and unspecified, again, showing the favorability of quitting at the time of diagnosis. Now, as it relates to systemic therapy, I wish we had a lot more data than we do. On the left-hand side of this panel, you see drugs that we commonly use in treatment of lung cancer. And in this next panel, the enzymes in the liver, the cytochrome P450 enzymes that metabolize these particular drugs. And cigarette smoke can induce these hepatic enzymes, increase the drug clearance of some of these molecular targeted drugs and chemotherapy agents. And perhaps our best example is erlotinib, where the response rate is lower in lung cancer patients who smoke, and it would really require twice the normal dose to get an effective blood level. We have suggested evidence for some other TKIs like sunitinib in kidney cancer, where the survival was shorter. And we also have in chemotherapy inferential evidence that when you smoke and take a drug like irinotecan, the serum drug levels are less and there's less neutropenia. And one would assume there's less biological effect and therefore less likely to impact the cancer in a constructive way. So then we get to the issue, what's the tobacco smoke doing to the immune system? Because now we're using immunotherapy as sort of standard practice in the management of most types of lung cancer. Well, the polycyclic hydrocarbons in tobacco smoke cause breaks in DNA, which form these bulky DNA adducts, which then get repaired by nucleotide excision, but may result in mutations. And with continued smoking, smokers develop a distinct mutational signature characterized by transversions of cytidine and adenine. And it's quite different from never smokers. And in addition, smokers may have ineffective DNA mismatch repair. And that smoking-related signatures has been reported to lead to a better response rate and survival outcome with the immune checkpoint inhibitors, the anti-PDL and PD-1 treatments. And how does that come about? Well, it appears that benzoate-pyrene, one of these substances in tobacco smoke, can lead to upregulation of the PDL1 mediated by a particular receptor, aryl hydrocarbon receptor. It's there to regulate the immune system. It leads to higher levels of PDL1 expression on the tumor cells, which helps them then to evade the immune system. And studies have shown that higher levels of the aryl hydrocarbon receptor and PDL expression occur in smokers, and that these patients then have a greater clinical response to immune checkpoint inhibitors like pembrolizumab. Now, tobacco smoke can also affect many other parts of the immune system. I've just listed them here just to show that this is not simple. It's very, very complex how tobacco smoke is influencing not only the immune system, but the tumor microenvironment, activating inflammatory immune response, upregulating T cell function, regulatory T cell function, decreasing natural killer cells, changing B cell activity and antibody production, and suppressing dendritic cell maturation activity. So there's a whole lot of things going on with the immune system when people are exposed to tobacco smoke. And the first systematic review of smoking in response to immunotherapy was in 2018. There were just 6 studies which showed a higher overall response rate among the current and former smokers, thought then to be due to higher PD-L1 expression in the tumors and a higher mutational burden. A more recent meta-analysis on 24 trials and over almost 14,000 patients showed that the immune checkpoint inhibitors significantly prolonged overall survival more than chemotherapy in smokers. And with subgroup analysis, monotherapy with ICIs significantly improved overall survival versus never smokers. And ICIs plus chemotherapy achieved better overall survival in both smokers and never smokers. So in the special issue, again, there was an article. Lead author was Lucy Cork, from fellow at Princess Margaret Hospital, and you see fellow colleagues at Princess Margaret Hospital. And she prepared these forest plots which showed the overall survival in advanced non-small cell lung cancer with first-line immunotherapy or chemotherapy by smoking status. So here you have the current smokers. You see some benefit favoring those smokers who are receiving immunotherapy. Here are former smokers where the benefit seems to be greater, and the never smokers where there's no benefit of the immune checkpoint inhibitors. This is in second-line immunotherapy, and here we have ever smokers. So these are people who could be current or former smokers, and you see benefit, whereas in never smokers in the second-line situation, you don't see a benefit. So from the conclusions of the studies on immunotherapy, either monotherapy or combination immune checkpoint inhibitors is superior to chemotherapy in current smokers. And monotherapy or dual ICIs are less effective in never smokers. And so maybe the optimal approach in the never smoker who is expressing PD-L1 would be ICI plus chemotherapy. That's current thinking. And of course, we know that continued smoking, and one of the reasons to get survivors to stop smoking is the risk of a second primary. There are lots of studies that show that the risk of developing a second lung cancer is 6 to 24-fold that of a never smoker. Another reason to encourage patients to stop smoking. And in our lung cancer clinics, we know that 20 to 30% of the lung cancer patients are smoking at diagnosis. The majority of these people want to quit, but have been unable to do so because quitting permanently is very difficult to do. And most individuals who are successful in quitting have made 30 or more quit attempts before they achieve permanent abstinence. And the reason simply being the withdrawal symptoms, which peak after several days of quitting and gradually diminish over a week or so. And so most people who relapse are going to go back to smoking in the first week or so after they made their quit attempt. And it's kind of discouraging in a way to see that only 3 to 5% of smokers will be abstinent 6 to 12 months after an unassisted quit attempt. But cancer is a teachable moment, and patients may be more motivated to quit at the time of a cancer diagnosis and therefore more likely to succeed. So we need to educate our patients about the health benefits of quitting, including the fact that they'll have the potential to live longer, survive longer, to have fewer toxicities, less risk of recurrence, less risk of a second primary. And there's a question about when to ask them and when to advise them about a quit attempt. I think we should be individualizing it and predominantly doing it around the time we see them in consultation, but being selective because some people can't manage the large burden of information we give them at that time. And we have to recognize that most of these people have already tried to quit multiple times in their lives and have found it extremely difficult. So they need empathy. And I'd like to emphasize the word empathy over and over, and support in order to help them quit. And it's interesting that in a study done at Princess Margaret Hospital by Lawson Ng, that the vast majority of patients felt that discussion about smoking cessation should occur at their very first visit, and that 88% felt that that discussion should be with their oncologist rather than other members of the healthcare team. Now, I get a lot of pushback from oncologists because they're terribly busy and they don't necessarily want to take on one more thing. But this is interesting information, and just oncologists supporting the messaging provided by nurses, radiation therapists, and others would be really, really helpful to encouraging patients to quit. And as it relates to readiness of cancer patients to quit, it's quite interesting that new lung cancer patients at PMH, 60% of them were very interested in making a quit attempt in the next month, and another 18% somewhat interested. And pretty much the same thing with those with head and neck cancer. But who do oncologists think should provide the smoking cessation? Well, about 1% of them think it should be them. They would much sooner see someone else trained in the clinic to do that. And given the busyness of cancer clinics, I'm supportive of physicians just having a quick comment to the effect that smoking cessation is one of the best things that a cancer patient can do to get the best outcomes from their cancer treatment, and then referring the patient along to the resources that are available to them. The barriers to implementing smoking cessation in thoracic oncology clinics could be a lack of knowledge. Hopefully this talk helps to deal with that to some extent. It may be a lack of skill communicating with a person who uses tobacco, or a lack of empathy towards those people. And hence we do need to learn some communication skills of how to speak well to individuals who smoke, remembering that there are factors that got them started typically when they were quite young. Their parents may have smoked. They may have been influenced by peers. They may be risk takers and they got started early, or they may have had very negative childhood experiences. All these things increase the risk of a person becoming an adult smoker. But there are also some genetic factors that determine the age of onset of smoking, and even the number of cigarettes smoked per day, and ability to stop smoking, which is determined by a number of genetic variants. And we have to remember too, smoking's pleasurable, and when you inhale, within about 10 seconds of inhalation, the nicotine hits your brain in those pleasure centers and rewards you with a good feeling. So it's very difficult to give up this habit. So we need to, I shouldn't have said habit, this addiction. It's extremely hard to quit. So they need all the support they can. So lack of resources is sometimes the issue. And one of those resources is access to nicotine replacement therapy. Many of our patients are in the lower socioeconomic levels, and increased price of or cost of NRT could be a barrier. This study was very interesting. It's the only one I'm aware of that shows the impact of treatment adherence by providing free access to NRT. It's a study from Turkey of 518 tobacco users. And 22% of them were able to obtain free drugs. Basically, what they saw was the quit rate was 14 times higher in those who were fully adherent, and adherence was related to availability of free NRT. So what we can be working towards in our cancer centers, and are trying to do this across the board in Sunnybrook, hopefully we'll be engaged with all of these things, and we'll hear more about your RAAM program, which is a smoking cessation counseling program in a moment. But availability NRT through Center for Addiction and Mental Health and their STOP program. We're implementing this in a number of regional cancer centers now. And we also have implemented in a few tobacco use survey, which allows you to determine the status of the patient smoking over time. So at every 3 months, to know if they're a current smoker or they've quit. If they're a current smoker, you could be encouraging them again to go into a smoking cessation program. If they have quit, then to encourage them to stay abstinent. So those are things that we can do. And I just wanted to end with this position statement from the International Association for the Study of Lung Cancer, which I'm sure the lung oncologists are all members of, that all patients with cancer should be screened for tobacco use and advised of the benefits of tobacco cessation. Those who continue to smoke should be offered evidence-based tobacco cessation assistance, which is really NRT and other pharmacotherapy plus intensive counseling. We should have educational programs on that incorporate tobacco cessation training and empathetic communication into all of our education about cancer management. And we should be capturing smoking status during clinical trials that we do. And then we could learn more and fill in the gaps that we have currently about the impact of continued smoking versus quitting as it relates to systemic therapy, immunotherapy, and even in radiation oncology. With that, I'll stop, and I think we'll probably have time for questions at the very end.
Thank you, Dr. Evans. As Alima said earlier, I'm Darby. I'm the professional leader for radiation therapy, but also her counterpart as regional co-lead for the smoking cessation program. So we do have a couple of other speakers, and just to, I think you very eloquently showed us the evidence of the importance of quitting smoking. I'm going to talk a little bit about the challenges that we have implementing, but more just to bring all the clinicians up on the call up to speed on what is the current state of what we have to offer patients at this moment. So this is a general, very more pictorial roadmap of how patients come into our system and where the smoking cessation efforts are usually concentrated. And I think we're unique, and it even starts at the beginning with registration, is that the patient could check in at main reception or the breast center or have a virtual consultation, and there wasn't enough words for there, or I would say, and especially pertinent to lung, be seen at one of the satellite clinics. So there's various pathways that the patient, when it's their new patient visit, comes into the center. And we recognize the physicians almost undoubtedly 100% do identify smoking status when they conduct their history and physical. And of course, that's, you know, translated into their dictations, and may advise them to quit as well. Most would, but it's now the piece of how do we connect them to the services. And so if they don't have a nursing colleague or one of the other support staff that know the services or access to the appropriate materials, if they're at a satellite or a virtual clinic, this could be a challenge. So we have implemented that nursing should also be assessing for this during their new patient assessment. So the idea is that all new patients would eventually, in a perfect world, get a nursing new patient assessment, and the smoking would be done using the 3A model. What we also have in place, because we know it's still not a perfect world, as I said, there's multiple inputs, therefore nursing doesn't necessarily get to interact, is for the radiation therapy patients, which we call our catch-all role, is a little bit further downstream in treatment, where radiation therapy can monitor if this has been done and follow up, pharmacy for select systemic patients, and then maybe nursing if they engage throughout. And then we do recognize, as a smoking cessation program, there's huge opportunity with transition to survivorship and how we actually follow up with any intervention that's done, which has never been done to date. Alima, next slide, if you're. So just where we do capture our data, and I'm going to speak a little bit about this after, that is reported to CCO, is through Mosaic. So it is, as I said, the 3A model. It's 3 quick questions. Is a new patient asked, so do you smoke or have you utilized tobacco products in the last 6 months? Yes or no. Advise. Did you advise them of the benefits of quitting? And then act is where you refer. So I think this is the most important part of what we're going to talk about, is what referral options do we currently have at Odette, because they have changed sort of since pre-pandemic. So right now, and you will, this is an old slide, so I won't talk. We'll move on. We have either referring via one of the telephone counseling, or as Dr. Evans already referred to, go ahead, Alima, is a RAAM, which is a rapid access addiction medicine clinic through the main hospital. And Alima, is Rachel online to talk about this?
I'm sorry, I don't actually see her online.
Okay,
so thanks.
Sort of, there's 2 services. These flyers and the referral forms are in all the clinics, and if anyone on this call wants information, connect with Alima and I. So on one, they've been sort of following with 2 options. They were trying and have put together all the material for a virtual smoking cessation group. And it was meant to be 4 weeks of supported counseling with a very stepwise program, information and support for nicotine replacement therapy. It has been challenging with trying to assemble enough people to run the group and the timing. So on the side, Rachel Samuel, who is the social worker that works with RAAM, We'll also do one-on-one counseling if you refer your patients to them. So we're trying for more of a direct referral option within Sunnybrook rather than farming out to only what's offered sort of provincially. So this information is available in clinic. Again, if you want more, connect with Alima or I. They're in the process of, I believe, hiring a nurse practitioner to help with this clinic because there was one previously that moved on. Next slide, Alima. So the other, and this is where everything gets very confusing, is originally this was, if we remember back, with Smokers Helpline. And then when Ontario Health was formed, they stopped funding Smokers Helpline. So then it became Telehealth Ontario. Telehealth Ontario then about maybe a year ago transitioned to something called Health Connect Ontario. And now we've just learned it's turning into Health 811. So on one hand, it's very confusing for patients to figure, or not both patients and providers, I would say, to figure out what the option is. But we have now learned from Ontario Health that we're getting updated referral options, and always before anything was referred to a previous service was supposed to be pushed along, but it's hard to know if that ever happens. But this will now be the external sort of provincially offered solution that we have for patients. So there in all the clinics will again be the brochures and the pamphlets and as well the referral clinics, so you can do that. So they are providing, it seems like a little bit more enhanced support services than what was done previously with Smokers Helpline and Telehealth. So the quick coach will walk them through. There is also a connection to nicotine replacement and the option to arrange face-to-face counseling or group support. So those are the two main options that we are able to provide at this point at Odette for our patients with the resources we have. So next slide, Alima. So just the other in terms of education pieces, CCO Ontario Health have produced a number of information brochures or just pamphlets to talk about the benefits of quitting smoking. Again, these should all be stocked in your clinical areas. The one on the left that you see, quitting smoking, is actually to advertise an e-module that they designed also to help patients understand how it can affect their treatment and their cancer, and some tips and resources to point them towards quitting. Next slide, Alima. So additional resources, we've also tried to do as best as we can with the limited web support. We've updated our external facing website to provide patients with all the same information that we provide them with inside the clinic, as well as there's previous videos that were produced by the past smoking cessation team. So all that is available and up to date currently. But again, just to remind, our recommended referral options are RAAM and Health 811, which we will, now that we know and everything's been rebranded, we are going to send out a center-wide communication so that everyone is very aware of these, because with the revolving name, it got very complicated. Next, Alima. And just last bit is a little bit about what our data is, how we are actually doing. So this is just the third quarter data. So we actually, the center saw over 1,300 new patients, and 67% of them were screened, which is actually probably pretty close to what the provincial average is right now. Not necessarily the goal, but the average. I see Dr. Evans nodding. So 11% of those patients did identify as smokers, and 71 of those were advised. So we're doing a reasonable job of advising on the benefits and recommending a referral option, but then you go down to accepting referral and it is very, very low. And I will say, I don't think this is a true representation of the number that are referred. I think we have data issues, and we also have confusion amongst what our referral options are. So next slide, Alima. So just again, as I mentioned before, it is not the greatest solution, but currently, and for many years now, all of our smoking cessation data has come out of Mosaic. This is also where our radiation therapy data comes from. So as you can see there, no wonder it's confused. That's still telehealth, because we didn't even get to update it to Connecting Ontario because we already knew the other change was coming. But now we know there's going to be clarity that we should have two stable options for a while. Moving, next slide, Alima. So just for everyone's interest, and I did see Sonali and Sean are on the call as well, so our nursing colleagues. So this is a snapshot of what the nursing new patient assessment looks like in Mosaic. What to know, every time you see these fields, they are exactly the same data elements, so it doesn't matter where you are entering them, it will be captured. But just to know, in the nursing new patient assessment, the initial assessment, which asks if you have used tobacco and advised on the benefits, is on one tab. And next slide, Alima. The interventions, which is where you would put the referral, is on another tab. So this is my slight shout out to Sean and Sonali. If you are ever completing this, a reminder that when you need to put the referral in the intervention. We think this separation is causing a bit of possibly us missing some referrals, but it's just as an awareness. Yes. If there's any physician on the call that's really interested in entering data in Mosaic for us, which I know there's not, but also feel free to reach out to us. Next slide, Alima. And actually, now I'll pass it off to Alima, who can talk about some of the regional program activities.
Thanks, Darby. So Toronto Central, North and South, yearly we put together a smoking cessation community or practice event. So just wanted to highlight this for you. This is the Smoking Cessation Champions, as well as patient and family education and the psychosocial support leads. So we have a selection of speakers lined up for the morning of May 3rd. And topics will include e-cigarettes in the cancer setting, health equity and what it looks like in smoking cessation, ideas on some digital health strategies to implement, and this could be just some ideas looking forward as we think about a new EMR and how to document. And Darby's spoken about what it looks like in Mosaic, but just some ideas to think about in the future. We also will be having 5 smoking cessation programs present on their programs. So Rachel Samuel from the Sunnybrook RAAM Smoking Cessation Service will present there, along with Health 811, Talk Tobacco, Smokers Helpline, and I'm forgetting one, CAMH's Stop program as well. So if there's multiple options out there available for our patients, and sometimes it's hard to know which one would be best for our patients, as well as if someone has tried one and then we want to motivate them to use another one or so on, it's just good to know some of the other options out there. So they will be providing some information about their program, what's unique, and how to refer patients to them. We'll also have a patient be part of a panel along with those 5 programs to talk about their barriers to seeking services and what they looked for in a specific service. And then we will have someone speak on motivational interviewing in short encounters. So how to engage with patients when we're only speaking with them about smoking cessation for just a short period of time. So we hope that you can attend, but if you're not able to attend, please still register with the Zoom link there, because then we'll have your emails, and then we can send out a recording after that. So if you're still interested, please still register. And you're not able to attend, please still register. So I think that's it from our end. Does anyone have any questions or feedback for us?
Sean, I see your hand up.
I just wanted to say that it's what Dr. Evans said about the physicians really encouraging people to with smoking cessation is really so important. When I first came to the Odette in 2011, we were, approaching every patient about smoking, and we were part of a study that was asking how did we feel about doing that with patients. And unfortunately, the last time I was in lung clinic last week or the week before, every single patient I spoke to, I saw the thing with the 2 tabs, but didn't have any ability to make referrals because every single patient was like, no, I'm not quitting. Or their family member who was smoking was like, no, not quitting. So one said they would decrease and they were planning to go for radiation treatment. We talked about, you know, like it's not helpful with radiation treatment, everything. So I think it's really important to also have the physician have that conversation with the patient. I find that they're more receptive when the doctor has said, you need to quit smoking, and then asked us to come in and back it up with all the information and options.
Sean, I agree with you entirely. I think that, you know, the physicians have been somewhat reluctant to do this. And my understanding is a combination of busyness and worried about getting sort of into long discussions about smoking cessation, how to do it, etc. And what I repeatedly tell them is that it's just a short script, and maybe we have to give them the script or have it on a lanyard or something. And cessation, quitting smoking is one of the best things you can do to get the best treatment results. Now, my radiotherapy will work better and you'll have less toxicity. My chemotherapy will work better and you'll have less toxicity, etc. It's a little more complicated with immunotherapy, as you saw from the slides, but I think it's really important that doctors reinforce the message and not leave it to the nurses, because if you saw the data from Princess Margaret Hospital, the patients expected to hear from their oncologists about it. If the oncologist didn't say it was important, then they're interpreting that it's not important. And no matter what the nurse says or the radiation therapist or the social worker, the doctor didn't say anything about it. And I also worry that even if we get them all convinced in the cancer center that it is the right thing to do, they may go back to see their family doctor and the conversation might go like this. So they told me the cancer center I should quit smoking, doc. What do you think? And if they don't know about the health benefits after a cancer diagnosis of quitting, they're very likely to say, and some in particular with an advanced cancer, well, you know, I think that you smoked all your life. It's going to be hard to stop now. I wouldn't worry about it and undo all the conversations that you've had to convince them that they should do it. So we have a lot of work to do to get everybody aware of the importance of cessation at the time of a cancer diagnosis. I think there's still lots of healthcare professionals, even within our cancer centers, because I've talked to most of the cancer centers at one time or another, who are still not believers that it makes that much difference. As our treatments get better and better too, is another reason for trying to get people to quit smoking. You take a disease like, say, metastatic melanoma, which used to be incurable. Now we have 10-year survivors with modern immunotherapy and so on. As people live longer, we need to help them stop smoking so they don't get other cancers or non-oncologic diseases. So it's really becoming more and ever more important that we take smoking cessation in the cancer center seriously.
Thank you.
Dr. Zeldin?
Yes, thank you. Yeah, I enjoyed this talk from all the speakers. When I was in clinical practice as a thoracic surgeon, I used to use both the carrot and the stick approach with my lung cancer patients, especially those who were facing surgery. The carrot approach usually worked better, and that's where we would emphasize the benefits of smoking cessation, especially preoperatively. The carrot, the stick approach was that you're not having surgery unless you quit. We didn't always do that approach, but occasionally it was the only thing that would work. The worst thing that we see in terms of the surgical approach, of course, are complications post-op. And the smokers, up until the time of surgery, there's no question, have a much higher rate of respiratory complications post-operatively. And anything we can do to get them through the surgery safer is obviously a bonus. So, we've been at this for a long, long time. We have better data now, as shown by Dr. Evans, that there are all kinds of benefits in terms of quitting. as soon as the diagnosis is made.
Well, thanks for your comments, Rob. Good to see you. I think the stick is probably limited in the cancer environment, but in the orthopedic world, that is a definite tool that orthopods use because they don't want to operate on people and do joint replacements and things and have it all get into trouble with non-healing. So they tend to be more aggressive about it than we have a difficult problem, I think, with cancer patients saying we're not going to operate on you if you don't stop smoking. But you know, what I wanted to say about how we communicate, I talked a little bit about sort of the empathetic approach, understanding that this is an addiction, understanding that it's extremely hard to stop, and if you do quit, you're likely to relapse. And it's got to be this encouraging approach and non-stigmatizing. And one of the things that many are trying to encourage is using language different than smoker. Now, I used it extensively today because it just takes longer to say tobacco user or other nice ways of describing it. But using the term, talking to people, are you a smoker, is in itself stigmatizing, and we should try and delete that from our language when we're actually talking to the tobacco user. So that person-centered language is being encouraged. I submitted a recent publication and got criticized for using the term smoker in it. So it's becoming, it's forcing us to think a little differently about how we talk about and talk to individuals who use tobacco.
So there's a question from Sonali in the chat. Does the RAM clinic have a virtual telephone component? And actually, yes. Okay, Alima's going to zoom back to the poster. So their initial idea was to create a virtual smoking cessation group. And this obviously came up and arose out of the pandemic. So the idea has always been to run it virtually. They just haven't been getting referrals. And I think it's in part due to a little bit of communication. They previously weren't advertising. And I think Alima and I've really tried to help them and connect them to the right people. But there is all of the material and all the structures together to offer this group virtually. And they have done it successfully at least once, maybe twice. I'm not sure, because there was a second one scheduled to go. So yes, so their main focus was to run this, but have found that they can't always get enough people to make it worthwhile, which is why the one-on-one counseling has also been offered. In terms of pharmacies, I can just address, certainly the Odette pharmacy is quite reluctant to take on any sort of nicotine replacement at this point. We've had other conversations and did actually loosely explore, could we participate in the stop pilot with that Cancer Care Ontario was running. And the main hospital pharmacy used to be, but it was really focused on Schulich heart. So it's one very significant gap that we know, that we don't have a great way to connect patients to nicotine replacement, but they will through RAM. So that's at least better. And we know, and now, well, according to the brochure of Health 811, they will, but so that hopefully will help fulfill the need. So
I'll just add there a little bit. So recently we did have a patient that was referred to the RAM clinic, and they were able to refer them out, connect them with NRT and prescribe it to them. And so we do know that it is a service that they do offer through their RAM clinic. Rachel is a social worker. So there is a through the family health team, they do refer patients directly to the physician, and then they can prescribe the NRT to them as well.
I think our greatest need, or needs, I'll say plural, are both access to free NRT, and at least it's happening increasingly, one through the CAMH Stop program and through your RAM program, and probably through Health 811, because it clearly has been a barrier for many. But the other thing that comes that stands out to me in reading the literature is the importance of intensive counseling. So this sort of one and done isn't going to work very often. In fact, it probably doesn't work hardly at all. It's intensive counseling, 15 minutes weekly for, if possible, 8 weeks, that sort of thing. And for individual patients, longer. It requires a lot of support. And that's where we just don't have the resources. And I've unfortunately seen over time with Cancer Care Ontario centers that when push comes to shove on the budget, it's the smoking cessation counselor job that gets cut to save some money, whereas it's probably one of the more important jobs in the whole cancer center. And I hope through Ontario Cancer Plan 6 and continued agitation and a heightened awareness of the importance of this, that the centers will get the necessary resource to have more folks who can do the kind of motivational interviewing and so provide the support that these patients need to quit. But we're a long way from having what's really needed. Hate to end on that note, but we're making progress.
Dr. Ong?
Hi, thanks. That was a great talk from all of you. I'm wondering if there isn't another point in the trajectory that we should introduce smoking cessation, and that's really when they finish the treatment, because they're all bombarded with so much information that they are overwhelmed. And once they finish the treatment, that seems to be sort of like a more teachable moment to say, well, maybe you've done well. Do you want to think about smoking cessation? And there might be a higher acceptance rate. Ideally, yes, we'd like them to stop before the treatment so that the outcome is better. But overall, we sort of lack that follow-up after they finish their treatment for smoking cessation.
Yeah, I think that's a great point you make, E. And in fact, a very large proportion of patients who do quit at the time of diagnosis will go back to smoking 6 to 12 months after they finish treatment. So having a conversation at the end of treatment, even if they've been successful in quitting, to encourage them to stay stop. But if they weren't able to quit during treatment, to indicate that in terms of staying well, reducing risk of recurrence in second primaries, and avoiding other kinds of complications from smoking, really good to make that point at the end of treatment and at intervals. And that's one of the reasons I'd love to see Sunnybrook adopt the tobacco use survey, which is just a couple of questions added to the symptom reporting through Isaac, the ESAS scales. And then you could have it flagged if the patient is smoking, at 3-month intervals, and renew those conversations about smoking cessation. The patients a lot of them are going to relapse. This is an addiction. It's a very tough one to deal with, and I'm sure you've had the experience I've had of take someone through some really tough treatment, say for small cell lung cancer, and then you're doing a follow-up assessment in 6 months, and you look, it's a lady, you look down in her open purse and you see the Demoriers looking back at you. It's very, it's a terrible addiction for the patient. It's terribly frustrating for the physicians, but again, we have to be empathetic about it and encouraging. And I agree, it's a great suggestion at every encounter to talk about the benefits of staying abstinent from tobacco.
I guess it's hard to end on a high point in any of this discussion, actually. So, Dr. Menjak, do you want to say any closing words, since I think we're pretty much out of time?
I'm not sure if I have closing words, but I think it's one thing that I was thinking about a lot is also it's not just that one individual, it's their home situation, their family, and if their partner can be supportive, or are they also smoking. So I think we always need to keep the patient's context in mind. And I think it really is important for the physicians to mention it, because a lot of times that's what they kind of hinge on, and that's what their partner's hoping that we will say. So I think everybody has a role to play.
Well, that's a good point to
all
end
the
on.
work that you do. Thank you all. That was a great talk. And we'll end there.
Thanks, everyone.
Thanks.
Thank you.